Okay, Dr. Hemant, we will start the presentation. So I would like to give the the brief bio of Dr. Hemant. Dr. Hemant did his MBBS from Jeepmar Parajuli and completed his MD in Community Medicine from PGI Chandigarh in 2011. His experience includes 3 years as a teaching faculty in public teaching hospital and more than 5 years as a senior operational research fellow with the International Unions Against TB and Lung Disease. His current role involves building capacity in and conducting operational research in low and middle income countries. He facilitated as a senior mentor in the WHO TDR endorsed structural operational research training initiative, SORT IT courses, regional as well as national courses. He has mentored more than 60 SORT IT participants and published under 20 research publications. He has led a series of research papers on the benefit of active case finding for the TB in marginalized and vulnerable population of India. He hails from Pondicherry, India, and currently stays with his father, spouse, and dog in Bangalore. You will speak on a recently published review of TB COVID-19. That is on the potential impact of COVID-19 response-related lockdown on TB incidence and mortality in India. The floor is it's over to you, Dr. Hemant.
Thank you very much, Prajjwal, and thank you for that introduction. And thank you for NESCOM, the Nepal Society of Community Medicine, for giving me this opportunity to present this review article. So this review article got recently published in Indian Journal of Tuberculosis, and Anurag Bhargav, who is a professor of medicine from Yenepoya Medical College, Mangalore, came up with this idea. And we started with this paper sometime in May when we got this reports of under detection of TB within the routine national TB program. And then we thought this could have, and there were some modeling studies coming up. And then during those times, we also had these news articles about the migrant crisis, the reverse migration, and the possible impact of lockdown on worsening impoverishment and worsening undernutrition status. So we thought, why not, write a review article on this and give some numbers, to bring out the seriousness of this problem as to how lockdown can result in increase in TB incidence and mortality. So let me proceed now. So the purpose of the webinar is obviously I'll be sharing the findings of the review article. So I'll give a brief background about it, followed by lockdown-induced poverty and undernutrition and its impact on TB incidence, followed by underdetection of TB and its impact on TB mortality. Then I will share the recommendations that we have given in this article, followed by limitations and conclusion. And then we'll open for discussion, comments, question and answers. So the background is that, before I start, we need to understand that I'll be using two terminologies. One is estimated TB cases, and the other term is, notified or reported TB cases. So estimated TB cases are the estimates that WHO and country gives as to how many, TB cases are there. Notified or reported TB cases are those that are actually diagnosed and reported within the program. So the difference between estimated and notified TB cases is equal to the missing TB cases, right? So similarly, there is a term which we can use, which is estimated TB deaths and notified, or the observed TB deaths within the program. So we should always remember this, that there are two terms, estimated and notified, and estimated is always more than notified, and the gap between them is the missing cases or missing deaths. And when I use this term called as TB deaths or mortality, these are TB related deaths. Okay, so that means any death that happens anytime during the TB treatment. Fine. So with this, let me start, give an introduction about TB incidence. So the estimated TB incidence globally per year is 10 million, and for India it is 2.69 million. So if you look at these estimated cases that are that are estimated per year, these are incident TB cases. This is in India it is more than 25%. When you look at TB deaths, it is estimated that there are 1.3 million TB deaths globally, and in India it's estimated that it is 450,000 deaths per year. Now these figures are for the year 2018, and this is based on the Global TB Report 2019. Another important number is 354 million. Now, what is this number? This is the estimated latent people with latent TB in India, or you could also call as TB infection. Now, when I talk about the above figures, that is estimated TB, I mean TB disease, that is 10 million globally and 2.6 million in India. So this is very important to understand. So 354 million people are estimated to have, TB infection. Now this 354 million is roughly 35 crores, and this is more than the population of United States of America. Fine. So this is an important number. We'll get back to this later. Also, India has, targeted to achieve the SDG target of 2030, which is TB incidence, reducing the TB incidence by 80% when compared to the 2015 values, and reducing the TB deaths by 90% when compared to 2015. Now, the SDG target to achieve this is 2030, but India, under its National Strategic Plan for TB Elimination, has taken this bold step. Many of them are critical about this, whether it's achievable, but it has taken this bold step to say that we aim to achieve the SDG target of 2030 by 2025. Now, in this background, now all of us know India is not different from world. We have had this COVID pandemic hitting us, and our first case started late in January, and these increased to 500 to 1,000 reported cases in March. So as a result of this, the government decided to impose a national lockdown, and this started on 25th March. And this national lockdown continued till 31st of May. So a total of 68 days. And this national lockdown initially was, with the aim of, what should we say, controlling the epidemic within the country. And later on, we have realized that, it's more of a mitigation. But the purpose was to improve our health infrastructure, to address the expected increase of cases, to improve our, availability of PPE, improve the testing capacity, because our preparedness in March was really dismal. So what happened as a result of lockdown is that there were many people, and it was also observed that there was a lot of worsening of poverty and undernutrition, and there was also an underdetection of TB. And as a result of these two, we think that this is going to impact TB incidence and TB mortality. How? We are going to discuss this later. Now, first, let us focus on lockdown-induced poverty and undernutrition and its impact on TB incidence. First, a background of poverty and undernutrition in India. So, Government of India in 2011-12, based on the MCPE, which is the mean per capita expenditure, in its report shared that 22% of people in India live below the poverty line. So we can say 22% of people are poor. So if you look at a population of generally 1.3 crores, it's roughly 28 crores people who are living below the poverty line. World Bank has stated that if you look at the absolute numbers, highest number of poor people live in India. And if you look at the undernutrition figures, 23% of adult women and 19% of adult men have a BMI less than 18.5. So we can say that 23% of adult women, that is roughly 1/4, and 19% of adult men, that is roughly 1/5, 20%, are undernourished, that is BMI less than 18.5. Now this is more in rural areas, especially in Uttar Pradesh, Bihar, Jharkhand, and Odisha. These are the states of India. And this is more, this percentage is even more in scheduled tribes and scheduled castes and among people who are poor. And if you, WHO says that if prevalence of low BMI, that is less than 18.5 kilogram per meter square, if it is more than or equal to 20%, that means it's a serious problem. So therefore, we can conclude that in India, undernutrition is a serious problem. And in the lowest 30% of the, if you divide the poor people into, tertiles, in the lowest 30% of poor people, this prevalence of undernutrition increases to as high as 39%. And it is also very well known. Now let us look at the association between poverty and undernutrition. The poorest 30 consume less than the minimum consumption requirement. Now the minimum consumption requirement, they say, is around 2,300 for males and around 1,800 to 1,900 for females. And it's also seen it's not just the consumption is low of calories, but the quality of consumption, the quality of food that is consumed is also, you know, poor. For example, in rural households in India, they consume less pulses, less green leafy vegetables, and less fruits. And if you see, the source of protein in most of the rural India and among the poor especially is cereals. And we know that if the source of protein is only cereals, then, you know, the quality of protein is poor. We need a combination of cereals and pulses, or at least, you know, you can have a protein from non-vegetarian sources. And to note, only one state in India consumes more than 40 grams of proteins per day per capita. Now, this is the, you know, per day consumption that is recommended. That is per person on an average, they should consume more than 40 grams of protein per day. But it's only one state in India, I think it is Himachal Pradesh, if I'm not wrong, that consumes more than 40 grams of protein per day. So we can conclude from this slide that the consumption of calories is low among the poorest populations, poorest 30, and not just the consumption of calories is low, the quality of food in the form of less pulses, green leafy vegetables, and fruits, their consumption is low. And the quality of proteins that is consumed is mostly cereal based and not based on pulses and on non-vegetarian sources. Now, to strengthen this, you know, to strengthen the public distribution system, there was a National Food Security Act that was enacted in 2014, where they said that, you know, we'll try to improve the coverage of existing PDS, that is, increase it to 75% among rural population and increase the coverage to 50% among urban population. And under this, 5 kg of wheat and rice will be provided at subsidized rates. So per family, you get 5 kg of wheat at 3 rupees per kg, and per family, you get 5 kg of rice, one of these two, 5 kg of rice at 2 rupees per kg. And only 2 states in India give pulses. So you can see the public distribution system is also cereal centric. And on top of that, some states may give sugar and oil, and it varies from state to state. But there is a problem with PDS. It is very well known and published that there are problems with targeting and there are operational inefficiencies. Let me give you one example. Now, undernutrition is really common in Uttar Pradesh and Bihar. These are the 2 states which I think 20% of India is in Uttar Pradesh and in Bihar. Now, when you calculate those who are eligible for PDS, that is the beneficiaries of PDS, this calculation is done based on 2011 census, but the population has grown since 2011 census. So the central quota of how many people can be covered under PDS is already full. So whenever someone applies for registration under the public distribution system, their application, you know, is never sees the light of the day. This is for new people, people who are in families who want to newly register with PDS. So beyond that, there are also problems with targeting. The poorest of the poorest families, maybe they're not registered with PDS, or if they're targeted, then there are operational inefficiencies. There are losses in the pathway from, you know, the godowns all the way. And also there are issues about quality of PDS. So now let us look at poverty, undernutrition, and its association with TB. So we can summarize till now that the poverty levels in India are high, and among the poor, the undernutrition is very high. The quality of food, the consumption of calories is low, and the quality of food is also poor, and the protein consumption is also low. Now it has been seen that self-reported TB is 4 times higher in the lowest wealth quintile. Now, if you distribute the population into wealth quintiles, that is, arrange them in increasing order of wealth and divide them into 5 equal half, the lowest wealth quintile has 4 times higher prevalence of self-reported TB when compared to the highest wealth quintile. And it is also known from various studies in India that they're very less, but the studies in which the socioeconomic status or the BPL status of the patients are collected, it has been found that half the TB patients belong to below poverty, are from below poverty line, that is BPL. So you can say that TB is a disease of poor, and it affects the poorest of the poor. Now, let us look at the association between calorie and protein deficit and TB. Now, it has been shown that a low BMI is associated with TB, and it's strongly associated. You can see the adjusted hazard ratio is 12.4. And it has been found that low BMI is the strongest mediating effect between poverty and TB in India. So if you look at poverty and its association with TB, there are various mediating factors in between, and low BMI has been found to have the strongest mediating effect. When you look at protein deficit is also associated with TB. A low protein intake, that those who consume less than 50% of proteins than what is expected, have higher chances of developing TB. Similarly, those with low serum albumin and low serum ferritin, which are this is serum transferrin. This is a typo error. That is, those with low serum albumin and low serum transferrin, they are associated again, higher chances of developing TB. Now in Zambia, association, this is very interesting for protein deficit, association between low socioeconomic status and TB prevalence was mediated via low protein intake. And let me give you a background. In Zambia, the TB epidemic is driven by HIV because the HIV prevalence there is very, very high. But despite that, the population attributable fraction of low protein intake was more than HIV. So for low protein intake was 42%, and for HIV it was 37%. In other words, if you have 100 patients with TB in Zambia, in 42% of them, it is because of low protein intake, and in 37% of them, the TB is because of HIV. So low protein intake has an important role to play in development of TB, not just calorie deficit. So therefore we know now in India, there are high level of undernutrition, and there is, high prevalence of latent TB. I showed that in my first slide, which is 354 million, it's estimated. So what happens is undernutrition, both calorie deficit and protein deficit, impairs innate and adaptive immunity. And as a result of this, there are high chances of this latent TB, this 354 million people with the latent TB, for this to be converted to TB disease. And it's been found through studies that 32 to 42% of TB in India, it's attributable to undernutrition. So in other words, if there are 100 TB cases, of those 100, approximately 40 TB patients, in them the TB has occurred because of undernutrition. So this is very important. The population attributable fraction for undernutrition is even more than HIV, diabetes, smoking, and harmful use of alcohol combined. And this has been, given in the Global TB Report 2019. So undernutrition is the key. So if you tackle undernutrition, you can, bring down TB by 40% in the population. So now, till now, I've discussed, what are the levels of poverty, undernutrition in India, the association between poverty and undernutrition, and then the association between undernutrition and TB. Now let us look at what has been the impact of lockdown on undernutrition and poverty in India. So pre-lockdown, that is before March, India had slowing GDP growth for the last 3 quarters. There was rising unemployment. Around March, unemployment figures were around 6.7%, and there was low demand. Low demand means people were trying to save and not willing to spend money. And further, this was worsened as a result of lockdown. Let me give you some examples. The Center for Monitoring Unemployment in Center for Monitoring CMIE, I'm getting what's the full name, has reported that in March 2020, the unemployment rate was 6.7%. And in May, the unemployment in India increased to 27%. So the lockdown started on 25th of March, and the nationwide lockdown continued till 31st of May. And it is International Labour Organization estimates that around 400 people from unorganized sector have been pushed into poverty because of lockdown. And various economists have estimated another number, that around 354 million people have been pushed into poverty as a result of lockdown. So this is roughly 40 crore and 35 crore. Those who are comfortable in using crores, and India's population is roughly 130 crores. So you can say roughly 20 to 25% of the population is getting pushed into poverty in the background where 22% of the population is already below the poverty line. So this is really significant. So this is resulting in doubling of poverty levels. And during lockdown, central government and especially the state governments tried, distributing cooked food. And the central government started a scheme where they would additionally provide, in addition to what is given, 5 kg cereal for free and 1 kg pulses for free per month for, a household. But we need to understand, how much does 5 kg cereal per family per month and 1 kg pulses per family per month provide. So let us take for a 4-member family, if you're giving 5 kg cereals, it basically gives 167 grams of cereals per day. In other words, this is 500 kilocalories of cereals, kilocalories through cereals per day. And if you convert this to per capita, 167 by 4 would be how much? At least 40. Yeah, around 41 to 42 grams of cereal per day. But if you convert that to calories, it's roughly 125 kilocalories per capita per day. And if you assume, and if you double this, because this is additional and they are already providing 5 kg cereals under the PDS, then roughly if someone is dependent on the PDS per capita, they would only get around 250 to 300 kilocalories per day. Now many families are dependent. So just being dependent on PDS is not going to sufficiently provide you the cereals to help you meet the per day requirement. And recommended daily intake per day for light work for males is 2,320 calories, and for females it's 1,900 kilocalories. Let's come to pulses. So if you're getting 1 kg pulses per family per month, so for a 4-member family, you're getting roughly 33 grams of pulses per day. If you convert it to per capita per day, it is roughly 8 grams of protein per day. But the requirement, at least the consumption should be at least 40 grams of protein per day. So again, if someone is dependent, and I'm not adding additional pulses because 1 kg of pulses is being provided as a part of a scheme because of lockdown, but it is not being provided. Pulses, but for 2 states, are not being provided routinely. Second, now if you look at, okay, so government is distributing cooked food, and government is also increasing the provision of PDS. Many states like Delhi and Kerala, started giving PDS irrespective of whether you are registered under PDS or not. So the states came up with innovative strategies. But studies were done, right? 21 days into lockdown among migrant workers, 96% did not receive ration, 70% did not receive food, cooked food, and 50% had ration left on for 1 day only. So you can imagine, despite the massive scale at which government tried their best to provide cooked food or give additional rations, it was not sufficient. So let us look at the impact of lockdown on undernutrition. So before looking at that, let me give you a number. So for 1 kg weight loss, there has to be a 7,500 kilocal. When I use calories, it's kilocal, okay? 7,500 kilocal deficit. So if I have a 7,500 kilocal deficit over 1 month, I'm going to have a 1 kg weight loss. Now this deficit is consumption minus expenditure, right? We have to be clear about this. So if there is a, so let us assume if there is a 250 calorie deficit per day over 2 months, this will result in a 2 kg weight loss. So you can just recalculate based on the above statement. And this, according to me, is not impossible. If you're not, if your PDS is, giving only 250 kilocal per day of energy, if you're totally dependent on PDS, if your PDS is giving only 8 grams of protein per day, that if you receive PDS, if you're not receiving PDS, and among the poorest of the poor who do not have any job, I can imagine that 250 kilocal deficit per day is possible. And if it happens over 2 months, it will result in a 2 kg weight loss. Or in other words, if there is a 500 kilocal deficit over 1 month, it will result in a 2 kg weight loss in a person. Fine. So this is, not an unimaginable thing that could happen. So for an average height of Indian of, it's roughly 163 for males and around 152 for centimeters for females, a 2.3 to 2.7 kg weight loss would mean a decrease in 1 unit of BMI. So why I'm trying to correlate weight loss with BMI, I'll come to it later, but this is one more figure. You can back calculate this. But we calculated if there is a 2.3 to 2.7 kg weight loss in males and females, that would result in a mean decrease in BMI by 1 unit. So therefore, we can safely tell that 250 to 500 kilocal deficit over 2 months would mean decrease in 1 unit of BMI. Fine. So we can say that it is possible that among the poorest, should we say the poorest 30% or poorest 20%, it is possible that at population level, there could be on an average 1 unit decrease in BMI. So now let me introduce a study that we have used. This is a study by Knut Lonroth. This was published in International Journal of Epidemiology. And this study says that there is a consistent relationship between BMI and TB incidence. And it's an inverse relationship. This study says that a reduction in BMI by 1 unit is associated with an increase in TB incidence by 13.8%. And there is a confidence interval of 13.4 to 14.2%. This was based on 6 cohort studies that they reviewed. So let us apply this. So what we assumed that half of TB is related to undernutrition. This is in a worst case scenario, right? Related to undernutrition and poverty. We saw that 32 to 42% of TB is because of undernutrition. So we can assume an increase in TB by 185,000 cases. How did we calculate this? We multiplied 13.8% with the estimated annual incidence of TB in India, which is 2.69 million. I gave this figure in my first slide. And I divided by 2 because I'm assuming that half of the incident TB is because of undernutrition. So this TB, additional 185,000, we can round it off to 186,000 cases may happen over a period of 1 year to 2 years. So these are huge cases. So if we say that there are 2.69 million incident TB cases, if we add this 185 or 186,000 cases, this would 2.69 million would increase to 2.88 million incident TB cases. And if this is just based on, reduction in BMI, which is based on a reduction in calorie consumption, that is reduction in weight. But if we consider the effects of reduced protein consumption, because that is also independently associated with TB, development of TB, the increase would be even more. Now, let me give you examples. So one number to remember is that we are estimating that because of worsening of undernutrition, because of lockdown, there would be an additional 186,000 incident TB cases. Again, these are estimated incident TB cases in India. Now, let me give you some examples from other countries. Now, you may say, has it happened before? Yes, it has happened before. Let me give you an example for Cuba. So Cuba from 1960 to 1990, over 30 years, had a 5% annual decrease in TB notification. But what happened in 1990 and 1991, that there was collapse of USSR, and Cuba was dependent economically on USSR for many things. And there were also sanctions by United States of America. So therefore there was an economic crisis in Cuba. As a result of this, in 1994, the per capita calorie consumption was only 1940 kilocals, and there was a 32% reduction. So if it was around, should I say, if it was around 2600 kilocals, it reduced to 1940 kilocals per capita consumption as a result of the economic crisis. And this resulted in a increase in annual notification of TB by 50% between 1994 and 1991. So if, the TB notification was 100, it increased by 150. So this has been documented because of, economic crisis, reduced consumption of calories, that resulting in undernutrition, and that has resulted in increased annual notification of TB. Let me give you another example of Zimbabwe. Globally in 2008-2009, there was an economic crisis that affected Zimbabwe as well. So in 2008-2009, there was an economic and nutritional crisis that resulted in a 35% increase in TB incidence in 2 hospital areas. Now you would say, how can you say that this increase was because of nutritional crisis? This can be supported by a point, because in Zimbabwe, again, TB epidemic is driven by an HIV epidemic. But in the meantime, between 2001 and 2011, there was a decreased seroprevalence of HIV among antenatal women. So in the background of decreasing prevalence of HIV, we can attribute, again, this is ecological data, but still we can attribute that this 35% increase of TB, academically we can't attribute because we have to go for individual based studies, but we can say that economic and nutritional crisis was associated with 35% increase in TB incidence. And in 2010-2011, it returned to normal. There was again, once the economic crisis subsided, there was a 33% decrease in TB incidence. So we have discussed, undernutrition, poverty, and its association with TB, and what is the impact of lockdown in worsening undernutrition and therefore resultant impact on TB incidence. Now let us look at the second aspect of the review article, that is underdetection due to lockdown and its impact on TB mortality. So remember, we tried to look at association between worsening of undernutrition due to lockdown and its effect on TB incidence. Here we are looking at the effect of underdetection due to lockdown, underdetection of TB, and its impact on TB mortality. So let me give you some figures. So we went to the NICSHE website. This is the web portal of the National TB Program. And this website gives you the updates of number of TB cases that have been notified. And if you put a time range between this period and that period, it gives you nationally and state-wise how many TB patients were notified. So when we look at the period between 25 March and 19th May, this was during lockdown. This was an 8-week period. And when you compare this period with the pre-lockdown period, again of 8 weeks between 29 Jan and 24th March, we found that there was a 59% decrease in TB detection at national level. In other words, if in pre-lockdown period, 100 TB patients were notified, during the lockdown period, the same duration of period, only 41 TB patients were notified. That means a decrease in notification of 59%. In other words, 59% under detection. Now you would say, why do you compare it with the pre-lockdown period? Compare it with the same time previous year. We did that as well. Just let me increase the light because it's grown dark. We did that as well. We compared the period 25 March to 19 May 2020 with 25 March to 19 May 2019, and there was 62% decrease in TB detection. So if you compare with previous year same time, the under detection was even more. Now, if you look at state-wise, it was the under detection was more than 70% in UP, Bihar, Andaman and Nicobar Islands. Leave Andaman and Nicobar Islands. It's a very small union territory. UP and Bihar constitutes 20% of Indian population. And this is where the health system is also relatively weak. This is where undernutrition is also very high. And here the TB under detection was also high, more than 70%. It was less than 30% in states like Odisha, Arunachal, Mizoram and Sikkim. Odisha is in East India, Arunachal, Mizoram and Sikkim are in Northeast India. And there was no effect on under detection, that the detection was similar to the pre-lockdown period in Lakshadweep and Ladakh. Again, these are, small union territories with very less TB notification. Now, this horizontal bar diagram gives you the distribution of under detection. If you look at India, it was 59%, and highest was Andaman and Nicobar Islands, which is 77% under detection. Uttar Pradesh and Bihar, it was 73%. Andhra Pradesh, Tamil Nadu, Puducherry, Madhya Pradesh, Gujarat and Chandigarh was, more than the national under detection of 59%. And other states, but this is still significant. Rajasthan, Jharkhand, Maharashtra, Manipur, Delhi, Telangana, Karnataka, West Bengal, again, large states. These had around 50 to 60% of under detection. So let us come to impact of lockdown. So what is the impact of under detection on TB mortality? So this was an, article or this was a item that came in World Health Organization's Pan-American Health Organization, PAHO, and this was authored by Philip Glasio. He is part of the Stop TB department of WHO, and this came in on 5th of May 2020. And this article, stated something, and this is what caught the attention of Anurag and me, that why don't we do a similar calculation for India? What did Philip say? Philip calculated that if we assume an average 25% under detection of TB globally over a period of say 3 months of lockdown, there would be an additional 190,000 deaths in 2020, which is a 13% increase in TB deaths in 2020. Now, there was an assumption. This is assuming that in a post-lockdown period, there is no rebound increase in case detection. Let the case detection post-lockdown be similar to the pre-lockdown period. This was the assumption. So this is, he had predicted globally, and most of the countries have been going into lockdown, that there would be a 13% increase in TB mortality in 2020. Now, we applied the same in India. Before we do that, let us try and understand what calculations he did. So to begin with, he calculated something called as perturbation, denoted as D in this formula, that is called as perturbation of TB detection and care. And he gave a formula which is 1 minus MA by 12. Now, where M is the number of months for which the lockdown was implemented, and A is the average monthly under detection in percentage, right? So D is equal to 1 minus MA by 12. I'll repeat, where M is the number of months for which the lockdown was implemented. A is the average under detection in 1 month divided by 12. Shiv Shah, you have a question. Do you want to ask the question now, Prajjwal? I could see him raising his hand. Over.
Dr. Hemant, I think we'll take the question at the end of the presentation.
Okay, so we'll give sufficient time for questions. So participants don't have to worry that I'm going to run away immediately after the presentation. Prajjwal, one more thing I wanted to confirm. Are you able to see me well? Because it has become dark here and I've turned my table lamp on. Are you able to see me?
Yeah, we can see you. Yeah.
Okay, fine. Because we are in this twilight or dusk, no? This is called as dusk in the evening. So, okay, fine. Thank you for that confirmation. So we calculate something called as perturbation. So what we did, we calculated 1 minus, instead of M, we took W, okay? And so we calculated we calculated an under detection for a period of 8 weeks, right? Starting from 25th of March to 19th of May. So we used weeks. So if you look at the denominator, divided by 12 is nothing but the number of months. So if you use weeks, the number of weeks for which there was a lockdown, then instead of 12, we should use 48. So we use the formula 1 minus WA, where W is week, A is the average under detection per week divided by 48. And we calculated the perturbation for India. Fine. So the perturbation is null at D is equal to 0 and maximum at D, perturbation is null at D is equal to 1 and perturbation is maximum if D is equal to 0. Okay. Let's proceed. Then he calculated the TB mortality during pertubation. Okay, so let us ignore what is this MD for now, and let us also ignore this H. H is for HIV. So let us forget that we are calculating separately for HIV or non-HIV. Let us just focus on this formula and try to understand how they are calculating mortality, estimated mortality, and then we calculate mortality with pertubation and mortality without pertubation. You subtract it and you get the mortality attributed to the perturbation due to lockdown. So this is the formula we used. Just for the case of clarity, I'm clarifying what this formula means. So this is basically nothing but the first part that you see here, I minus dt by fu, is the mortality among those who are not notified, and the final notified and treated, and the final this one, which is dt into ft, is the mortality among those who are notified, and you add both, it's the total mortality. Very clear? So we have total estimated TB patients and we can divide them into those who are not notified, which is nothing but estimated minus notified, and we can divide them into those who are notified. We calculate the mortality among these two groups and add it. How to calculate the mortality? So I is nothing but estimated incident TB, and T is nothing but treated TB. So treatment is done among those who are notified. Okay, so what they're doing is they are multiplying T with D, which is the perturbation. Okay, so if D is equal to 1, that means there is no perturbation. That means T is same, right? If there is perturbation, that is 0.9, 0.8. So if you multiply it with T, the number of cases detected and treated are lower and number of missing cases would increase. So basically, let us assume that there is some kind of disruption of TB services, and that is factored by this variable called as D. So if you multiply D by T, T is those who are treated, you get the number of people who are actually treated because of perturbation. And obviously DT is less than T. Okay, T is those who are treated without perturbation, that is in the absence of lockdown, and DT are those who are treated during lockdown. For example, if perturbation is 0.9 and those who are treated is 100, so in the absence of lockdown, 100 people are getting treated, and in the presence of lockdown, 90 people are getting treated. So 10 people are getting added to the missing pool who never get treated. Fine. So 1 minus dt, sorry, I minus dt is nothing but those who are not notified during lockdown. Okay, and then you multiply it by case fatality among those who are untreated. U is untreated. Fine. So these case fatality percentages, that is those who are untreated, how many die, these figures are available in the appendix of the Global TB Report 2019. So you multiply the case fatality rate among untreated with those cases who are not treated, which is nothing but I minus dt. And then you among those who are treated, which is D into T, you multiply it with fatality among treated, and you get those who are dying among those who are treated. Fine. And then you add both, you will get the total estimated people who are dying. And this can be calculated both for those with HIV and without HIV. Hence, we have a sigma H, where H could be equal to 0 or H is equal to 1. H is equal to 0 means among those without HIV, we do the calculation separately, and among those with HIV, we do the calculation separately. So, and MD is this. And mortality in the absence of perturbation, basically you have to just remove D from the formula, which is I minus T into FU plus T into FT. Okay, so therefore, if you calculate mortality D, that is mortality during perturbation, obviously it will be more than mortality. So when you subtract MD minus mortality, you're going to get something called as delta M, which is nothing but as this. Okay, so what I basically did, I set up an Excel sheet using the estimated number of incident TB with HIV, without HIV. So I have that Excel sheet with me. Those who want it, you can write to me and I'll share that Excel sheet with you. If you want to calculate these numbers similarly for your country, you can use it. Now, just for clarity, this is a bit of rough work. I thought I'll share this with you. So MD is nothing but, let us forget HIV or not, that is going to create confusion. Simply, mortality during lockdown, which is MD, is nothing but I minus DT into fatality among untreated plus D into T into fatality among treated. Similarly, mortality in the absence of perturbation or in the absence of lockdown, we have to just remove the D, which is I minus T into FU plus T into F. It's common sense, MD will be more than M, okay? Therefore, delta M is equal to MD minus M. And if you go through this maths, basically you eventually get delta M is equal to 1 minus D into FU minus FT into T. Okay, so this is the same derivation that they did. 1 minus D is equal to FU minus FT into T, and they added a sigma of H because you do this calculation separately for those with HIV and for those without HIV, and you add them both. Simple reason being the fatality among those with and without HIV is different. Okay. So now coming to the calculations, considering the observed 59% reduction in detection over an 8-week period in 2020, we estimated an additional 87,711 TB deaths, which is roughly 88,000 additional TB deaths in 2020. In 2020, in the first slide I had shown, in India, you have 450,000 deaths per year. And if you add 88,000 deaths to it, it becomes 537,000 deaths. So which is nothing but a 19.5% increase in deaths. When you look at this uncertainty interval is based on the range of estimated incidence of TB. WHO has given a lower range and an upper range. So using that for India, we calculated the uncertainty interval. So if you look at the numbers, please pay attention here. 450,000 is the annual deaths that happen in India, the most recent numbers. If we add these TB deaths because of lockdown, additional TB deaths, we would expect around 537,000 deaths. This will surpass the estimated deaths in 2015, which was estimated 517,000 deaths. So somehow we decreased from 517,000 deaths in 2015 to 450,000 deaths now. But because of the lockdown, and if action is not taken immediately, these deaths in 2020, estimated deaths may increase to 537,000, and we may, lose all the gains that have been made in the last 5 years, and the mortality figures will be equal to what it was 5 to 6 years before. So let us give other estimates that others have calculated. These references are available in my paper. They have said WHO's Stop TB Partnership did a separate analysis for a 2-month lockdown and a 2-month recovery period. Over a 5-year period, there would be 5.7% additional deaths. McQuaid CF et al, calculated that again over a 5-year period, there would be an additional 150,000, deaths. So these are various calculations. The key thing is the numbers. These are huge numbers, and if you don't act now, these numbers will be a reality. So coming to the recommendations, right? So till now we have looked at effect of worsening undernutrition due to lockdown on TB incidence, TB disruption due to lockdown and its effect on TB mortality. So here are my recommendations. At TB program level, ensure routine TB services. We have to ensure this. At least routine TB services, health services should be ensured at least for poverty related diseases like TB, malaria, and leprosy, and other poverty related diseases, and other essential health services I'm going to extend, though I have not done the analysis, like NCD care, vaccination, maternal health. I strongly believe that we have to do adequate planning before implementing a lockdown, because these are then, what do you call, side effects. We went to save 10,000, 20,000 COVID deaths or 50,000 COVID deaths, but as a result of lockdown, we lose 90,000 patients because of TB. We lose so many people because of malaria and so on. So ensure routine TB services as soon as possible. Ramp up enhanced and active case finding. So we already have an active case finding strategy going on, but we need to ramp it up in high risk population, at least in migrant populations, migrant clusters, among clusters where you have a lot of poor people, or in clusters where you expect high prevalence of TB. We need to ramp it up. And also enhanced TB case finding, where enhanced case finding is you improve the access to TB and you do a lot of IEC in the community to ensure that people are encouraged to come and get themselves tested for TB. And in addition, so these two things are going to reduce the gap, are going to detect more cases, right? So the principle is, if you ensure routine TB services, you ensure enhanced and active case finding, you will not miss more cases, or you will detect more cases. You put them on treatment, mortality reduces, right? Number two is that among those that are detected, we need to screen for severe TB at diagnosis. This is not routinely done. Patients have severe alcoholism, they have severe malnutrition, but still, they're not seen by a doctor. Their BMI is 16 or 15. They are vomiting, they're not able to tolerate drugs, but they continue getting family or community dots. So what we are suggesting here, each TB patient at diagnosis has to be screened for severe disease using simple indicators like BMI, respiratory rate, ability to stand or not, and then classify it as severe TB, yes or no, and ensure that these patients are referred to district hospital for admission till they can be referred back to the community for ambulatory care. So the program needs to systematically plan for screening of severe disease, refer these patients, and clinically manage them through inpatient care for some time before starting them on inpatient care. This is very, very important, because most of the deaths in TB are early deaths. I can give you an example of Karnataka. In Karnataka, 25% of TB deaths happen before notification. Remaining 25% of the deaths happen within the first 7 days. Remaining 25% happen between 7 days and 28 days, and remaining 25% of deaths happen between 1 month and 2 months. So most of the deaths happen between the first 2 months. If you don't detect severe disease then and identify them, you will not be able to dent mortality. Now, beyond the TB program, we suggest that we increase the amount of rations and increase the amount of protein, that is pulses, that is given through the rations. And because, PDS, there are operational inefficiencies, issues of targeting, we think PDS only, yes, we do increase the amount of rations and protein, but this is not sufficient. We strongly suggest, we have suggested in the paper, direct benefit transfer for the poorest. That is, you identify some mechanism to identify poor people, maybe the poorest 20 or poorest 30. And in India, we have Aadhaar card. Most of the Indians are linked to Aadhaar, and do direct benefit transfer for poorest. We may wrongly give money for people who don't need it, but at least the poorest should get some money, like say 5,000 rupees, 7,500 rupees, so that at least they can buy money for food. And this is not just related to undernutrition, right? You don't have money, you will not go to an health facility. So therefore, not having money is not just related to undernutrition, it is also related to reduction in access to care. And in 50% of the TB patients in India, studies have shown they first go to a private practitioner. Then we suggest that increase rural employment through Mahatma Gandhi National Rural Employment Guarantee Scheme. This is currently happening. So under this scheme, in rural India, everyone is guaranteed for 100 days of job per year, and they are given roughly 180 rupees per day for that job. And then finally, we recommend social protection of migrant daily wage laborers. Currently, it happens, for example, you have construction workers who are working in an urban area in cities, there is a provision to register them under some construction welfare boards, but the registration is very poor. It is only 6% or 8%. The purpose of registration is to ensure that if they need any help, we can provide them help. And then if they are registered, these migrant daily laborers can fight for their rights and they will not be exploited. And if they are registered, then, you know, social protection can easily be done, where you can transfer money to, you know, people. Now, some of you might be confused that, you know, TB patients, already money is being transferred, but that is, in India, 500 rupees is given per month, but that is only for TB patients. Here, what we are recommending is to transfer money to the accounts of poor people. I'm not talking about poor TB patients, poor people, so that they have money, they can tide over this acute crisis, and we can, you know, mitigate the impact of lockdown on undernutrition and therefore on TB epidemiology. Further, we recommend that we can target these recommendations in states with higher underdetection and states with, you know, poor nutritional indicators and high load of reverse distress migration. So if you realize, the states are common. So those with higher underdetection, those with poor nutritional indicators, and those with high load of reverse distress migration, these are 2 or 3 states in India. Now, there are some limitations. Now, the numbers for India predicted in this manuscript are estimates based on modeling from other studies. For example, the Lonrod study, where we assess the association between BMI and TB incidence, this was based on 6 cohort studies from high income countries. So we have to take these results or extrapolation with a pinch of salt. Then we have not provided a combined effect of poverty, undernutrition, and underdetection on TB incidence as well as mortality, right? But the independent effect of poverty and undernutrition on TB incidence, these numbers are itself high. If you hide underdetection to it, because if you underdetect TB now, the transmission will increase within the community, and over a period of time that will also result in increased TB incidence, right? Similarly, we have shown the effect of underdetection and mortality, but poverty and undernutrition can also have an effect on mortality. As I said, if they're more poor, they may not go to a healthcare provider, they may never get notified, and they may die. So the numbers I believe we have provided are conservative, and still they are significant enough, and the true numbers may be even higher than this. So to conclude, I've prepared these 2 bar diagrams. Effect of lockdown induced poverty and undernutrition on TB incidence. Without lockdown, it is 2.69 million TB patients estimated per year. It may increase to 2.88 million. And lockdown induced TB underdetection, its effect on mortality. In India, in 1 year, we have 450,000 TB deaths. It may increase to 537,000 TB deaths, higher than the annual deaths reported in 2014-15. So to conclude, lockdown, this is my final slide, lockdown induced shock, though transient, through worsening undernutrition and underdetection, may have long-term effects if the unemployment levels do not reduce. Please note, everyone may think that this is a transient effect. So now if you have a 27% unemployment levels, the economy doesn't recover. The government's, whatever economic package they have given, if it doesn't help, then the unemployment figures may remain the same, or they may not return to the 6.7% figures. So these effects of lockdown may not just be transient, but also long-term. There is a potential for additional increase of TB cases and deaths. This has potential to reverse the gains made in 5 years. Hence, we immediately request steps to counter the economic and nutritional impact and ensure that TB services are returned to routine, followed by ramped up case finding and routine detection and management of severe disease at diagnosis. Over, guys. Thank you very much. Prajjwal, give me 10 seconds. Let me turn on the light in my room. Just give me 10 seconds, please.
Sure.
Yes, Prajjwal, I'm back.
Okay, thank you, Dr. Hemant, for your informative talk, and I hope the learned materials will be used in different countries for the control of TB incidence and mortality. Now the floor is open for discussion, and I request all the colleagues from different countries. I hope there's a colleagues from India, Nepal, as well as from Myanmar to put up the questions to Dr. Hemant.
Just 1 second. I need to block the light behind me. I'm very sorry for this. Give me a minute. Huh?
Okay,
Yeah, yeah.
sure.
Yes, I think that should be fine. No glare. Yes.
So any questions from the participants?
Prajjwal, Sujit had a question. He had raised his hand. We can also go through the comments box,
Okay.
the chat box. Sujit, if you're there, you can unmute yourself and ask the question, please. I think is not there. So let us open the questions.
Okay.
We have one question from Basanta Joshi. So how do you think the double stigma, one already on TV and another for COVID-19, will demotivate community people to visit health facility, resulting in delay in diagnosis and increase in death due to TB? So double stigma and double problem, like
yes, I agree with you, because what is happening on the ground is those who get tested for TB are getting tested for COVID. Those who are getting tested for COVID are getting tested for TB if they have more than 2 weeks cough or symptoms. So there's a bit of stigma, but I hope that's a very important point. And there are anecdotal cases where people are not visiting health facilities. Forget, I'm not getting into TB, I'm not getting into COVID. There has been personal experiences within my family where they are not visiting a hospital because it is locked down. So unfortunately, the message has not been conveyed, or maybe there was a miscommunication or not properly understood by the masses, that if you have a health problem, do not ignore it, visit the health facilities. And there is a problem of, police beating up people. It's not that simple. I have faced this. I can give my personal example. Let me not quote anyone else. I have an upper airway obstruction syndrome, which got worsened during the lockdown. And I tried to delay it because, I could manage it by delaying my food and, eating right stuff. But then my wife gave me a stick. You're being over smart. Let's go and show it. I showed it to an ENT specialist, my contact. They said, you need a surgery, but because we need to do tonsillectomy, this is not the right time. For a GRD, please go and visit someone. So I went for OPD. I was caught by a police person on the way. It was locked down. And I escaped because I was a doctor. I do not know if I was not a doctor, whether I could have escaped, because the attitude totally changed. But that is again an anecdotal experience, may not be the same with others. Over.
Okay, there is another question from Dr. Sudhi Nag. So are there any further studies for gender discrimination in TB detection or TB care during this lockdown period?
No, not that I'm aware of, but that's very interesting to see whether this is affecting females more. It's an hypothesis. It's affecting a particular gender more than, other gender. So that's very interesting, but I'm not aware of, any studies. Over.
So there is another question from Anurag. So on major, it's not question, it's query. Like on a major issue in India is the diversion of TB program staff to COVID-related activities. I think it's a toxic shifting.
Yes. Dr. Surya, if you permit me, Dr. Anurag is the lead author of this paper, and it's nice that he has joined. Anurag, could you unmute yourself and give your perspectives as well if you're there? Over.
Yeah. Thank you for this opportunity. I'm very happy to be part of this webinar, and excellent presentation by Hemant. So this has been troublesome for us for the last many years, and I think the whole TB, the perspective on TB has been very germ-centered, and we all know that most of the people, 90%, are able to just keep the latent infection latent, and only 10% of progress over lifetime. So of the factors which are making people progress to active disease, in India, which has a low HIV prevalence, it is actually undernutrition which is driving the epidemic. and so eloquently explained by Dr. Hemant. So when it is worsening in this economic crisis and a nutrition crisis, it is going to have an impact potentially on poor. So as community medicine professionals, we are all aligned with equity. And I think this is a where we need to really highlight the aspects of, access to food, access to healthcare facilities, maybe with the kind of influence that we have over things. And the COVID-related response has to be balanced with the restoration of health services, including TB services to the poor. And as Hemant said, we already have a huge population which is at risk of TB and is already suffering undernutrition. So this is a double whammy for us. There are very good examples from history where we all know the famous graph from McKeown that TB started declining in the West with socioeconomic improvements, and one of the major improvements was in the level of nutrition. So even before TB the first TB drug was discovered or the first vaccine was introduced, there was a decline, and that is what we should actually aim according to with a very active TB program. If we can influence this the risk factors like undernutrition concomitantly with TB services, that would really bring about the decline in TB that we want to see in our countries. Thank you so much. Over.
Thank you
Okay,
very much,
thank you,
Anurag.
sir.
Thank you.
So we have another question from Dr. Dilesh. It's more related to testing. Okay, how do you think TB testing has affected due to COVID pandemic at provider level? So what are this impact?
Thank you, Dilesh, for this question. So this has been our hypothesis actually when you go through a paper that we have said that, the possibility of under detection during the lockdown is because, people staying at their home, not going to an health facility because it's a lockdown, blah, blah, blah. Number two is economic aspect, don't have money to visit a doctor. Number three, even if they go, maybe the healthcare providers are busy in COVID. The hospital that they go has been converted into a COVID hospital, so no one wants to go there, or the lab technician that was there is now not available. He is busy in COVID work. Or if despite all these barriers they get tested, maybe the health staff doesn't have time to notify these patients. So we have discussed this in the paper, and what you have suggested is one of the reasons for under detection. Over.
Okay, thank you. So we have Dr. Leela from Nepal. So he said, what about the potential impact of physical distancing measures on TB transmission? So can this possibly reduce TB infection in the future?
Yes, very interesting questions. Yes, Suryaji, very interesting question, Leela. This has been an hypothesis, but I don't think that applies in India or a country like India, where a majority of our TBs, for example, 40 to 50% of our TB is through undernutrition. And the mechanism of TB is where they have latent TB infection, and because of undernutrition, it gets worsened. So I've opened the slide number 28. There's a study by McWade CF et al. In European Respiratory Journal. I suggest, Leela, you go and look at this paper. Unfortunately, Anurag, I made a mistake in referencing this, though we have referenced the content from this paper in the paragraph just before recommendations. I made a mistake in citing. So I even wrote an email to the authors saying sorry, but McWade CF et al. Have looked at these various scenarios. Effect of physical distancing on TB transmission vis-a-vis effect of physical distancing and lockdown on disruption of TB services and so on, right? So I would suggest you read this paper by McWade CF et al. And you will get your answer. If not, please feel free to write to me. We can discuss over email. My email is there in the first slide of the presentation. Over.
Okay, there is another interesting discussion or question from Nafis. So he said, this clearly derails our TB elimination target in 2025. So what rapid steps could help us to counter this derailment in terms of health system in the current context of COVID-19? I hope
Yes, thank you
we
very
have
much, Nafeez.
some answers.
I'll let Anurag answer that question. His experience, his work with national program before. Anurag, over to you. Can you answer this question, please?
Yes, so as Hemant pointed out, we have a very ambitious target in terms of reduction of TB incidence and mortality for 2025. So looking at the future with the present in mind, I think that may have to be substantially revised. And I think the most urgent concern is the present situation, not even gazing into the crystal ball for 2025, but countering this situation as it is evolving in India. So I think we urgently need to take the steps that Hemant has shown, ramp up services. I think the key thing is that somehow balancing the response to COVID with the need to provide these other services. And unfortunately, right now, I'm talking of Jharkhand, where I'm leading a trial. The TB staff is almost entirely, involved in testing for COVID, contact tracing, etc. So I think if we are able to address the problem today, we may still find some kind of a return to normality. But if we do not respond in a timely manner, then this year and as in the future years, we'll be we'll be lagging behind definitely our targets. So these rapid steps are the ones which Hemant has actually suggested, but also addressing the problem of the economy and the access to nutritious food.
Thank you. Anurag, I'll just add that point about TB mortality, where we have said that severe TB disease has to be detected at diagnosis, right? And we have talked to many clinicians and program managers, and they anecdotally tell that 20 to 33% of TB patients appear to be severe to them. That means at diagnosis, that means they need admission, they need inpatient clinical care. Maybe some patients need, a broad spectrum antibiotics. Some patients need, therapeutic nutritional care. Some patients need treatment of, alcohol addiction, things like these. And these are huge numbers. And it's very well shown that association between severe disease at baseline and its effect on mortality. And if you don't address that at diagnosis, you're losing an opportunity to reduce deaths. And the 2025 target for India, which is the SDG target for 2030, is to reduce the TB mortality by 90%. So, but this is not done routinely. Right? But if if a doctor comes across and assesses the patient, well and good, but it does not happen routinely for all the patients where severe disease is assessed. For example, in reporting, all the administrative units report, we notified 100 patients. Of 100 patients, 90 diabetes testing done, 80 HIV testing done. Of those tested, how many were HIV positive and stuff, right? So similarly, this kind of reporting is not done. 100 TB patients detected. That is the aggregate reporting. How many are severe TB? Because if you don't ask them, it will not be done. And the TB program gives a very simple indicator which can be implemented by the TB program staff, a non-medical staff, without the intervention of a doctor. And if this is done, if this indicator is added in the NICSHA website as well as their routine recording and reporting systems, it will go a long way, in addressing, at least it will be step one in addressing the issue of TB deaths. And we have taken this opportunity of COVID-19 to emphasize that step. This should be done, I believe, irrespective of COVID-19 or not. Over.
Can I add a comment to yours, Hemant?
Yes, Anurag, please.
Please.
Yeah, so actually, as Hemant said, that what we are doing in tuberculosis is what we do not do in any other disease. Actually, if a patient comes with a pneumonia, we always stratify risk. If the person is well, not breathless, not hypoxic, he is sent home. But if he has breathlessness or if he has an unstable vital sign, then he's admitted in the hospital. But for some reason, historically now, since the 1960s, all TB patients are actually sent home. In India, of course, in Nepal, it may be different, but there's a tendency to just implement domiciliary care in everybody. And if we are losing patients in the first few weeks of illness, then patients are not going to die of TB, they're going to die of severe TB. So if we identify those who require care and treat them, TB mortality will come down. And I feel TB mortality is really the low-hanging fruit that we should address before we even try to address incidence. So TB mortality can come down with provision of risk assessment and appropriate care. And we have actually reviewed this whole issue in a paper in Journal of Clinical TB in May 2020. It's a perspective paper. Please go through it. I would love any comments. It's open access, and I've sent it in the chat box. So I think this is something that should be done.
So Anurag, you have shared your paper in the chat box, is it? Where you have described the TB mortality.
We have another question from Ankur. Is there any robust study that speaks about increased risks of mortality in TB patients with COVID-19 regarding any comorbidities or death?
Yes, Surya, I'll quickly answer that. Answer is yes. TB is associated with higher mortality. I don't exactly remember which paper, but if Ankur can write to me over my email address, I will send the link of that paper. I think that study is led by Union. I'm not sure, but I can send that link over to him. So Ankur, if you're listening, if you can send me an email, I'll reply back with the study to you. Over.
So it's already conducted. Okay. So hope we can communicate and we can further study. From Basant Joshi, thank you, Hemant sir, for excellent presentation. And I think if government officials from Nepal were also present in the webinar, would have definitely, okay, if they were present in this good discussion, hopefully it will be easy for them to understand regarding impact of COVID-19 on their ongoing treatment of TB or any prevention program.
Surya, I'll quickly add a point here. So
Please.
One minimum thing they can do is they can share the abstract of the paper and the link, or there is Union has had a media release of this paper where they have again summarized the findings of the paper for a lay person, people in media, so that they can use that content to further disseminate the findings. So again, I'll share, while this thing is going on, I'll share that media link as well, and please share the summary of these findings. And I would encourage to do a similar analysis. So I'll just note down what all things I have to share. I can share the media release, the Union paper on TB COVID, and I can also share the Excel sheet which I used for calculation. We included that as a supplementary material, but unfortunately that is not provided in the paper. I can share that Excel sheet. So all these things at the end of the call, you can let me, I can share it to one of you, and then you can share it with other participants. Otherwise, those who are individually interested can write to me as well. I've shared my email ID on the screen, and I can give you the necessary information. Thank you very much.
Thank you. Definitely we'll discuss with our lay persons, community people, okay, through media brief, and the policymaker through policy reporter, policy review, and hopefully we can replicate same type of study in context of Nepal too, or in our different provinces. Hopefully NESCOM will lead soon regarding implementation of or finding from your paper, okay, in our country, Nepal. We have Naresh. He said also in BPL families, housing conditions are not so great. So practically social distancing may not be possible.
Yes, a valid point.
It's a valid point. It's also common in Nepal. It's almost similar characteristics both in India and Nepal. There is another question from Mahesh Puri. Can you please elaborate on qualitative aspect of this COVID and TB relation that made important changes in people in long run from a researcher point of view, researcher point of view, like lives of people, etc.
Okay, so can you elaborate on the qualitative aspect of this relation that made important changes in the long run? Okay, so I'm going to make a comment. Don't quote me. Yeah. I think that this has given a wrong, not just TB COVID, but in general about health seeking. This is my gut feeling. This could be wrong. And I'm part of a lot of political discussions online and, things like that. This has given a feeling to people that hum healthcare ke bina what you would think is this would increase the importance of, sensitize the people about the importance of healthcare infrastructure, primary healthcare, testing facilities, public health staff on the ground, having a separate directorate of public health, things like that. But people are realizing last 2 months, we have survived without going to hospital. And for the last 2 months, hospitals have had only 10% OPD attendance, but still, things are happening. As an individual, I can't see the deaths. I can't see the side effects of lockdown, but at an individual level, people have started thinking. So I'm just worried this should not have a negative impact on health seeking. I'll give you examples. I've had personal anecdotes where, not personal, family friends, someone with hypertension and severe headache for 10 days, not going to show to a hospital. And that led to a lot of side. That's my worry, that this thing should not give a wrong message to the public. I think it should not affect the health seeking in general. I might be wrong, but that's my feeling. Over.
Okay, we are almost into the today's webinar. So we have few questions. We have a question from Dr. Sudhi. So Dr. Hemant, there are remarks about state of people reaching for TB testing or treatment that delays leading to increase in mortality. So do you have any recommendation to lower this during COVID-19 time by TB program or from public sector or from private sector? So do you have any innovative idea?
Exactly. So Dr. Sudhi, we have shared this in the paper. We have strongly recommended ramping up, not just implementing routinely, ramping up enhanced case finding and active case finding. So what you would expect in enhanced case finding is IEC, where people are told that, if you have cough, that is through, more than what you do routinely. Maybe, I don't know, that's a call government has to take, whether it's to TV media, whether it's to print media, or whether it is to social media, to put this message across, that is enhanced case finding. And obviously enhanced case finding will only work if TB services are available. So, that the routine services should be implemented as soon as possible. And active case finding, where the system goes into communities and looks into cases. I think these are the two things, private sector engagement, yes, that is important, but I strongly believe in addition to private sector will be in the pathway once you do enhanced case finding, where you do IEC, people may go to government or go to private. So I believe ECF and ACF is key, ramping it up in the near future, and smartly, because that also has costs. IEC has costs involved, doing ACF has costs involved. So do it smartly so that we do it in a cost-effective manner. Over.
Okay, we have Philip from Kenya. He would like to thank for your great work and dissemination of knowledge to entire world. And we would also like to thank, NESCOM would like to thank Philip from our side too. And we have Preetam. So we'd like to thank you for your very interesting paper and presentation. Ankur would like to thank. Says a lot, I think, thanking you for your presentation. Hemant, any response from National TV Program or GOI, Government of India, regarding your dissemination?
Yes, thank you very much. We have shared it, but I think Anurag is more close. Anurag, any feedback from those in CTD if you have received?
They have, so they have said that they are going to, express this intent very strongly. But I think what is happening is right now in India, the COVID epidemic, the first phase was in the urban areas, and now it has showing up in the rural areas, and especially in the states which have high TB burden. So while other states are on stable or decline, it's actually COVID is increasing in those states. So I'm a little concerned whether their intent will get translated into visible, efforts there, because now they're coping with the increasing TB numbers, for example, in UP, Bihar, Jharkhand, etc. So, but they said that they are aware of this situation, they want to address it. But as I told you, the challenges are there, and I think more than the TB program, I think this decisions have to be driven at some higher level.
Agree.
So that the needs of the TB program are recognized, and they are not diverted for COVID response.
Anurag, I'll just add to that. So we have divided our recommendations in our presentation into those that are within the purview of TB program. That is, routine TB service to be initiated as soon as possible, ramping up case finding, and the detection of severe TB. This is under the purview. But other points like, having a, expanding PDS, that those are, policy level decisions, increasing the amount given, quality of proteins, giving proteins pulses, and then, things like the second point about social protection for migrant workers, giving money in the pockets of people. These are beyond the TB program, and this is directly within the purview of GOI. And unfortunately, India has tried its best, but I think if I can say, our economic package stimulus has not been in the form of giving money in the pockets of people. That has been very limited. But it has been more of, giving loans and giving more grains on the PDS and stuff like that. So we wish if Government of India still considers giving more money into the pockets of poorest of the poor so that they can tide over the acute crisis. Over.
Okay, thank you. We have Vinuta. So Vinuta would like to thank you for your generous experience and knowledge sharing. And we have some link, GUI link from Anurag sir. And we have Monish. So he would like to thank Dr. Hemant. So I think we try our best to cover all the comments, or feedback or questions in this webinar. So I'd like to hand over to Dr. Prajjwal. Do you have any question? Oh.
Yeah, I have a question to Dr. Hemant. Dr. Hemant, I want to know, you talk about, the undernutrition and the, increased incidence of tuberculosis in India. So, what has been the strategy of the Government of India to tackle undernutrition in the last 5 years, and what is the strategy after, post lockdown? So that is my first question, and the second question is,
okay.
You talk about the, the quality of does the quality of cereals which you provide free of cost, does it have any effect? Did you get my point? I think.
Yes, I've got your point. So quickly, I'll come to your second point. There have been, like, for example, Government of India has said that it will give 1 kg of pulses, right, under the scheme post lockdown, and this will be sponsored by the center, and this will be given free for, most of the all PDS account holders. But this is not taken off to the extent that one would expect. There are many states where it has not even started. There are many states where its coverage is poor. But these are all, newspaper items. And in many states, the discussion is confused at which dal to give, because this is a national policy. There are various dals available. That is coming to your previous point. I don't know. I think it is beyond my purview about what Government of India is doing for nutrition, because I'm not aware of exactly what it's doing. It's more to do with economic improvement, and therefore that trickling down to more money in their pockets. PDS, again, its reach is very low. The target is 75% in rural and urban. I'll request Anurag to add more light on this. Anurag?
So so actually, there is a national portion, this thing, nutrition mission. But the issue has been that most often the nutrition problem has been limited to children and pregnant women. So there has not been an adult focus or even adolescent focus in the nutrition programs. For example, the midday meal schemes in the schools actually ends when you are about 12 or 13 years of this thing. After 8th standard, you don't get any this thing. So that focus, I think, still has not changed. So you don't talk of adults, the problems of undernutrition in adults. And the PDS is a robust system. At least the network is there, but for some reason we have just been calorie centric and cereal centric. And we strongly feel that if pulses are provided not free of cost, but at a reasonable price, it would have a tremendous impact on morbidity and mortality, not just due to TB, but because of other diseases also. So when you talk of under 5 mortality in India, still we are losing lakhs of children because of undernutrition. Almost 50% of under 5 mortality in India is related to undernutrition. So actually, it would improve population health as a whole. And I think it's a no-brainer in the better off sections of society, we definitely see less disease, less severe disease than in the poor. And a lot of this is related to not only access to care, but also to the factors of, our diets.
Anurag, quickly, there is also issue of, being eligible for PDS and getting registered under PDS for new beneficiaries. Because of, there is not enough central quota or state quota left, because the base population that has been used for calculating the beneficiaries is 2011, and therefore, for various reasons, the application is just stranded, and for 2-3 years, you're not accepted under the PDS scheme. Am I right?
Yeah, so there are numerous issues with enumeration of the poor people, and as Hemant said, one population which gets left out are the migrants, because they are not in the state. They are working and living away. Sometimes the poverty surveys occur when they are away from the state. So, and they cannot access the PDS in the places that they are working in. So there are, very many issues about the estimates of poverty in India, and this has been a kind of a very tangled issue. But in general, if we were to apply some criteria, the general thing is that it is not very efficient to target these things to specific people. If you had something like a universal PDS with maybe higher, you could make the prices more in line with what is its cost. But in the targeting phase, a lot of people are missed out. In Jharkhand alone, for example, 20% of the really poor are not having a PDS card.
Thank you, Anurag. Yes, Prajjwal.
Surya, is there any more questions?
So I have no question from my side. So if you any participant has any questions related to today's discussion, or any rectification or any suggestion, so if you would like to share it in this platform, please proceed. If you have any. Otherwise we need to go for closing session. Do you have any question? Okay, so we'll try to share all the reference material links provided from Dr. Hemant in our official Facebook page and in Google Drive, and we'll share the link for further study, discussions, or coordination and collaboration. So over to you, Dr. Prajjwal.
Okay, thank you, Dr. Hemant, for your wonderful presentation. So I think we gain a lot from your presentation. Thank you, Dr. Anurag, for giving us the insight on the TV log, on the review paper of your TV. So we hope to work. The NESCOM, Nepal Society of Community Medicine, would like to work with you all in the coming future, and we are open to the different sort of collaborations in the future, so that we could bring down the incidence of TB in the Southeast Asian context. Thank you, Dr. Hemant. Thank you, Dr. Anurag, and all the participants, national and international participants.
Dr. Prajjwal, I'd like to add one thing. Regarding, if you want to present, if you want to disseminate your research finding or general, media related things or media briefing, so we are always happy to welcome you in our platform. Please feel free to communicate with us for betterment of science or betterment of our populations. So I'd like to add these things in this forum. Dr. Prajjwal.
Thank you, everybody. Thank you, Dr. Hemant. Thank you, Dr. Anurag, and all the national and international participants. Thank you very much.
Thank you very much, Prajjwal. Thank you.
Thank you very much, Dr. Prajjwal and Dr. Surya. Thank you.
Thank you.
Okay, so thank you all. So let me stop here.
Stop the record.
So thank you all for presentation, for active participation and interaction. So we'll share our recording in our Facebook page too, for future assistance. So thank you very much. So good evening, namaste.
Namaste.
Namaste. Bye bye.